Hi everyone, and I'm happy to present my presentation today about therapeutic exercise training for survivors of COVID-19. Well, the objective of this presentation is to talk about therapeutic exercise training and pulmonary rehabilitation and necessity of pulmonary rehabilitation for patients with COVID-19. Also to talk and to give an overview of the current recommendations and guidelines regarding therapeutic exercise training and pulmonary rehabilitation for survivors of COVID-19. So at the beginning, we will ask this question: what rehabilitation services do our survivors of COVID-19 require or post-COVID rehab require? Do they need kind of exercise training? Do they need what kind of support do they need? And that's the question that we are going to answer in the next slides and in this presentation, which is very important question to us. Well, pulmonary rehab, as we know, it is a very important component for rehabilitation, especially for chronic respiratory diseases, refers to the individualized rehabilitation treatment of patients with chronic pulmonary diseases. After doing a detailed assessment for a patient, we will prescribing individualized rehabilitation treatment of patients. It is a very comprehensive intervention that including exercise as its core component. It has also many components. It is not just only a pulmonary rehabilitation. There is a psychological support, nutritional support, educational, and behavioral changes component. So it is not just about exercise training. It is also the pulmonary rehab, including the psychological support and nutritional support, and maybe including also occupational therapists and other GP and also other specialists. And that's what makes it looking at the patient from different sides, because it's important, especially for survivors of COVID-19, as we will go to see in the next couple of slides, that the psychological support is also very important to our patients. The goal of pulmonary rehabilitation, it is not only to improve patients' physical and mental conditions, but it also focusing on or trying to help the patient return to family and to their society, because by making the patient better and physically, that's not the main purpose. Also mentally, this is also not the main purpose. The main purpose of the most important thing is to help them to return back to their family and society and engage in the community as there was before getting the disease. And that's the important part. So the pulmonary rehab help the patient to the survivors to improve their physical and mental conditions, also helping them to return to family and society by providing all kinds of support to them. With the development, as we know, of evidence-based medicine based on the recent recommendation, they recommended that the pulmonary rehab should be the core of standardized management of patients with COPD and the treatment option for patients with other chronic pulmonary disease. Also, there is the global initiative for obstructive lung disease, the GOLD, incorporated pulmonary rehab into the standard treatment for patients with COPD as early as 2001. Also, recently, Healthy China initiative they issued in 2019 and has also emphasized the necessity of including pulmonary rehab in the chronic pulmonary disease action plan. So pulmonary rehab is a very important for patients after recovery as a post rehab program, as you can as I mentioned in these recommendation and guidelines. Several high-quality clinical studies have verified the benefit of pulmonary rehab for inpatients, outpatients, and in-home patients. In this presentation, we are not going to talk about inpatients. We are going to talk outpatients and in-home patients. As we know, both together comes the home patients and outpatients in a certain way. Well, there's many benefits for pulmonary rehab: improved exercise tolerance, reduced number of hospital admissions and length of hospital stays, enhanced health-related quality of life, improved respiratory muscle function, relief dyspnea, enhances skeletal muscle function of upper and lower limbs, also alleviated diseases-related anxiety and depression. And if I want to go to talk more in detail, it takes, there's really more benefit of pulmonary rehab for patients with pulmonary diseases. I will talk just very fast about clinical manifestation of COVID-19. As we know, fever, cough, dyspnea, malaise. However, severe cases can rapidly progress to acute respiratory distress syndrome, ARDS. And just remember this ARDS because I will talk about it later on. Some patients also may have some kidney diseases, some liver diseases, cardiac diseases, and there's many theories behind why COVID-19 caused this kind of problem for other diseases and systems. The illnesses severity pattern so far observed this also follows some of them mentions about 4 categories, as we can observe even in our society and in our country. In Kuwait, there is asymptomatic infected patients. There is the second one, symptomatic patients isolated at home, symptomatic patients admitted to hospitals, and fourth one, symptomatic patients requiring ventilator support in critical care. Because COVID-19 has caused a public emergency, there's a lot of media talking about it. Patients with COVID-19 may demonstrate different degrees of psychological disorder, such as anger, fear, and anxiety, depression, insomnia, and loneliness, as well as lack of cooperation and abandonment of treatment due to fear of disease. Even when discharged, the patients may experience post-traumatic stress syndrome. And this, as we know, if we go back to the kind of we observe patient, if he is isolated at home, that will be less. Some of them have less. That's the least stress I think psychological stress will face. But when they are in isolated room in hospital and in critical care unit, they will have for a long period, for a long time, they will have this kind of mental stress and psychological stress, and they may need after discharge or support, psychological support, and they may need to do some exercise because, as we know, exercise helps to relieve and decrease depression, and also helps to mitigate the serotonin and the happiness hormone. The primary goals. So, what's the primary goals of the pulmonary rehab and by doing exercise? Is to alleviate. The short-term goal is alleviate dyspnea. If there's a dyspnea, they will be alleviated dyspnea, relieve anxiety and depression, as I mentioned before about the benefit of doing exercise and about the benefit of pulmonary rehab. And then what about the long-term goals? I mentioned before about returning back to society and to their family, preserve the patient's function to the maximum extent, improve his or her quality of life, and that's very important for our patients. Respiratory rehabilitation treatment for discharged patients. You can say there are two, you can categorize them to two types, mild and ordinary patients for discharge. Post and discharge rehabilitation of mild and ordinary patient may consist of improving physical fitness and psychological adjustment. We don't need that to do that much. We don't need much more effort to work with the mild cases. It depends on the case, of course, but you know, they are the mild cases. Progressive aerobic exercise can be selected so that patient can gradually recover to the level of activity observed before disease onset and eventually return to society, as I mentioned before, and they can impact the family. So it is important to work with the survivors, even with the patients gradually, not just very fast and going just instantly and immediately to the top level of intensity. Here, as you can say, we are working with very critical ill patients after discharged. Well, critical and severely ill COVID patients, with, they may have some respiratory dysfunction after discharge. That's why they should undergo respiratory rehabilitation. Well, that's based on a finding of a discharge severe acute respiratory syndrome and MERS, the Middle East Respiratory Syndrome patient, and clinically experience on post-discharge rehabilitation in RBC patient. COVID-19, that's why COVID-19 may have poor physical fitness, post-exertion, shortness of breath, muscle atrophy. Well, the muscle atrophy, including also the respiratory muscle, trunk and limb muscles, and also they may have post-traumatic stress syndrome. If I want to clarify more about this one, there's a study that's a 1-year follow-up of patients with ARDC showed that survivors of ARDC patients exhibit persistent functional disability 1 year after discharge from the intensive care unit. Most patients have extrapulmonary conditions with much wasting and weakness being most prominent compared with SARS. Pathological changes such as pulmonary fibrosis have not been dominant in patients with dominant in a patient with COVID-19. However, we speculate that damage to the lung and other organ system caused by SARS-CoV, especially in severe patients with ARDC, may lead to residual functional dysfunction, physical dysfunction of a varying degrees. Thus, the evidence for pulmonary rehabilitation of patients with SARS provides strong support and references for the development of pulmonary rehabilitation programs for patients with COVID-19. And that's why it's important for critical and severely ill COVID patients. They should, after discharge, they should go through respiratory rehabilitation. Important thing to say that a specialist should be consulted on precaution if the patient have comorbidity such as pulmonary rehabilitation, myocarditis, congestive heart failure, deep vein thrombosis, and unstable fracture before commencing respiratory rehabilitation treatment. It's important that the physical therapist who is supervising patients should be qualified and knowledgeable in the cardiac area and in the pulmonary area, because patient may come for us as a physical therapist with other comorbidity diseases, not only pure post-COVID rehab patients without any comorbidity. This is the only study I found. This is talking about respiratory rehabilitation for survivors of COVID-19 for elderly. And as we can see, the changes in pulmonary function and intervention group compared to control group is much higher in the intervention. Also, we can see also the pulmonary function compared to the control group. Here we can see that when they did like an assessment for a 6-minute walking test before and after, we can see the intervention is much significant. There's significant differences for the intervention compared to the control group. Yes, if you ask me, did they did an assessment or did they measure the quality of life and the mental status? Yes, and they found uh, very significant differences, the improvement in the intervention group compared to the control group. It's important in this study to mention that the elderly population is generally susceptible with a high incidence of severe disease and mortality. Community-acquired pneumonia in the elderly population has been found to result in a decrease, as we know, decreased activity of daily living, ADL, and the quality of life, combined by decreased physical and mental function. That's why respiratory disorders and lack of exercise in the elderly can lead to disease such as apraxia syndrome and pulmonary infection, especially if they are isolated in hospital or in critical care unit or whatever. Therefore, for for elderly patients who suffer from COVID-19 discharged with satisfying results, improved respiratory function is an important factor in maintaining active daily life and quality of life in elderly. And that's why it's important also to walk with elderly, and they should, I think, to receive them in pulmonary rehab program. These are some exercise consideration for people if we're going to work with them in the pulmonary rehab, especially if we're going to prescribe for them therapeutic exercise. If patients should be excluded if they are like have a heart rate, tachycardia above 100 beat per minute, blood pressure lower than 90 on 60, or above 140 on 90. Blood oxygen saturation is below equivalent or below 95%, or they have other diseases that are not suitable for exercises. We may need to terminate exercise if patient experience temperature fluctuation above 37.2, or the exacerbation of respiratory symptoms and fatigue that are not elevated with the rest, should discontinue exercise immediately. Uh, we may also consult physician if there's other symptoms, chest tightness, chest pain, dyspnea, severe cough, dizziness, headache, blurred vision, heart palpitation, reduced sweating, and stable gait. There's a lot of things. It is, you can say, a lot of similarity between pulmonary rehab and other programs, especially when talking about exercising, and these kind of symptoms comes out when the patient doing exercise. But also we need to take care when we're working with the survivors of COVID-19, because still there's a lot of unknown about this disease and what's kind of pathophysiology of this disease. That's why we need to keep asking patients and look for if there's any symptoms during the session for our patient, even after or before the session. So what kind of evaluation in the rehab setting? We need to do clinical evaluation, physical examination, imaging testing, laboratory testing. We can do also, we may do lung function test, nutrition screening, ultrasonography for the lung, for example, if we need. So what kind of facilities or like evaluation we can do, or we need to do? These are some of these clinical evaluation. We have also exercise and respiratory function evaluation. We can do, for example, for the respiratory muscle strength by using muscle maximum inspiratory pressure or on maximum inspiratory pressure. Or we can do also muscle strength by using manual muscle testing, isokinetic muscle testing. We can do also range of motion, joint range of motion test. Because we are working also with elderly, we may using there's different demography of patients in our program. We need to work on a balanced functional evaluation. We can use a Bell balance scale. Also, we are evaluating the aerobic exercise capacity by as we've seen in the study. They did 6 minute walking test. We can do also cardiopulmonary exercise testing if we can. We can also measure and see about the physical activity evaluation. We can use the international physical activity questionnaire. So many things, many tools we can use to evaluate the exercise and respiratory function. We can also evaluate the daily life by using different tools. For example, the Pathol Index is used to evaluate also the active daily life for our patients. So we can have also what's kind of respiratory rehabilitation intervention. We can have patient education, exercise respiratory rehabilitation recommendation. We will talk about it, and then evaluation of activity of daily living. Well, about the patient, as you can see in patient education, we can use a booklet and video that should be made to explain the importance and specifics and precautions of respiratory rehabilitation to increase patient compliance. Also, we can educate patient about healthy lifestyle, encouraging also patient to participate in the family and social activity. In the next step, we can talk about the exercise respiratory rehabilitation recommendation, and this is the latest one I found about recommending about the guideline and recommendation for the COVID survivors of COVID-19. It consists of three things. It's about the aerobic, strength, and balance. As you can see, it is not necessary to stick on this one because different patient comes with different things, different conditions, and so the aerobic exercise are customized according to the patient's underlying disease and residual dysfunction. These exercises including walking, brisk walking, slow jogging, and swimming, and begin at low intensity before progressively increasing in intensity and duration. A total of 35 sessions are carried out per week, and each session lasts for 20 to 30 minutes. Patients who are born to fatigue should perform intermittent exercise. For the strength training, we can say progressive stress training is recommended for strength training. The training load for each target muscle group is 8 to 12 repetitions maximum. Each group will repeat 8 to 12 movements. Also, the guidelines saying 1 to 3 sets per time with 2-minute rest interval between sets with a frequency of 2 to 3 sessions per week for 6 weeks. It is the same as that study that I showed you. Approximately 5% to 10% is increased per week. About the balance, also it's important to carry out in patients with comorbid balance disorders, including hand-free balance training under the guidance of rehabilitation therapists and physical therapists. It's important to keep in mind that patients may come with different comorbidity. They may have some cardiac disease, they may have some pulmonary COPD cases. So it is not necessary to stick using these guidelines and recommendation. And you can find this one in the reference because I referenced it in the reference. You can have it later on. But you should modify it to be as I mentioned to fit our patient condition. The final thing is about talking about ADL guidelines, basic active daily life, the patient ability in transferring, getting dressed, toileting, and bathing are assessed, and rehabilitation guidance is provided for these activities. Also, instrumental, the patient is assessed for to identify any disorder in task, targeted interventions carried out under the guidance, of course, of the occupational therapists. We are working with different specialists. For example, psychology support patient may need. We may need also occupational therapists. We need also nutritionists. So we are not working only by ourselves. Yes, the core component is therapeutic exercise training, but also patient may need other support also, additional support. Compared with the general rehabilitation for patients with chronic disease, we can say the most distinctive characteristic of rehabilitation is the effectivity of the disease. Therefore, it is the same procedure, the same regular pulmonary rehab we are doing. Just we need to take care for the COVID-19 characteristic, the infectivity of the disease. Therefore, it may, if the patient doesn't need that much work with, we can use the educational videos as mainly the educational thing can done through educational videos, brochures, remote consultation, or online teaching, so as to save protective equipment and avoid cross infection. Um, as I mentioned, some patients, and we may find they need face-to-face, or especially with the elderly, they may prefer to work face-to-face, so that we need to take care when we work with them. So take-home message, I will repeat again, and we should follow preventive measures where appropriate personal protective equipment according to local policy, and measures should be taken to avoid or reduce the risk. If there's a risk, at least a small risk of aerosol generation during intervention and activities. The second thing, mild patient or moderate COVID post survivors of COVID-19 illness exercise. 1 week should start with a low-level stretching and light muscle stretching and strengthening activity should be trialed period to targeted cardiovascular sessions. They should prepare themselves, they should prepare their body for exercise before doing very high intensity exercise. Patients in the severe category, they should be follow pulmonary rehab approach also. They should give them a very good education and introduction to pulmonary rehab. So because they may need that after discharge from the hospital. And for all of them, the final message is we should encourage patients and emphasize on being active and stay active all the time, especially after discharge, so that they will improve their physical and especially also, in addition, that will improve their mental condition. And the references, you can find it, and I will send the material to my colleague, Raj. And thank you, and I hope you enjoyed this presentation, and I'm happy to answer any question if you have. Thank you so much.